Hello, everyone, and welcome to today's webinar, Third-Party Reproduction 101 with Dr. Jamil Mroueh from Boston IVF's Rochester, New York location. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Jamil Mroueh is a reproductive endocrinologist at Boston IVF's Fertility Center in Rochester, New York. Dr. Mroueh received his medical degree from the American University of Beirut Faculty of Medicine, completed his OBGYN residency at SUNY Health Science Center at Brooklyn, and graduated his fellowship in reproductive endocrinology and infertility at Ohio State University Hospital. Dr. Mroueh specializes in all facets of fertility treatments and family building care. All right, we're going to get started. I'm going to pass it over to Dr. Mroueh.
Thank you, Alyssa. Good afternoon, everyone, and thank you for attending. So we'll be talking about third-party reproduction today. And just, a quick definition, third-party reproduction basically refers to the involvement of someone other than the individual or couple who plan to raise the kids, in other words, the intended parents. And I will talk specifically today about egg donation as well as surrogacy. So what is oocyte donation? Basically, oocyte donation, the first one was done back in 1984. That was the first time that a couple used an egg that wasn't theirs to have a child. It has been proven to be a very successful option for women who cannot conceive with their own eggs for many different reasons: advanced maternal age, diminished ovarian reserve, or a genetic disease. And basically, the whole idea is that it will allow a woman to carry and deliver a baby using her husband's genetic contribution or a donor sperm if she decides to do so. Who needs donor eggs? I guess the most important people we think about who needs donor eggs are people who went through premature ovarian failure. Either they were born without ovaries, they had surgery to remove their ovaries for cancer, for endometriosis, or other reasons. Patients who went through premature ovarian failure, they have fragile eggs, but also older women who, kind of missed the time when they wanted to get pregnant in their early 50s, late 40s, and who don't have any more adequate ovarian reserve to get pregnant. It's also used for male couples. We see a lot of male couples, same-sex couples who come, they're interested in having children. And in that case, we use their sperm, we use a donor egg, and we use a surrogate. And we'll both talking about surrogacy later on. Also, and it used to be more common in the past, women with rare genetic conditions who don't want to pass it to their kids. For example, before we started doing pre-implantation genetic diagnosis, women who had Huntington disease, women who had BRCA1 or BRCA2 and then want to have kids, affected by those conditions will elect to use donor egg. So there is really multiple reasons why a couple will seek egg donation. I would say, though, that the majority is because of early ovarian failure or age-related infertility. How are donor eggs selected? It's really a very tedious process. Why is that? Because, it is monitored by the FDA. It is monitored by New York State. We have those surprise visits, by FDA inspectors or by New York State inspectors to check to make sure that things are done properly. But basically, an egg donor should undergo a general medical screening. It's a pretty extensive medical screening. It goes through family histories as far as great-grandparents. It goes through any psychological issues that they have, any addictive behaviors, any medication that they are using, their physical appearance, weight, height, their genetic history, their medical history. They go through a very, very thorough screening, both medical and psychological. And usually donor eggs also, women who are interested in donating their eggs have to have a mental health evaluation also, just to make sure that there won't be any issues in the future with the recipient getting pregnant, or with those kids that were created with those donor eggs. Ideally, egg donors are healthy young women, usually between the ages of 21 and 34. Why 21? We feel that a younger woman, 17 and 18 and 19, may not be able really to understand everything that's involved in the informed consent that they have to do. It's a pretty complicated informed consent. As of why not older than 34 years, the younger, the better the quality of the eggs, the less the incidence of Down syndrome and other aneuploidy. So the ideal age, honestly, is between 21 and 34. It doesn't mean that older women are not, allowed to give their eggs. We get a lot of patients who want to use their siblings. She may have a sister who's 36 or 38. As long as she has adequate ovarian assessment, it's okay to proceed, but preferably the younger, the better. The recipient also need to be evaluated. There is also a psychological evaluation of the recipient. We want to make sure that she's comfortable with that whole idea of using somebody else's eggs. It's not gonna cause trouble between her and her partner if there is one. So she needs to be evaluated. At the same time, like any woman who want to get pregnant, she needs to be tested for all the infectious disease, make sure she's immune to rubella, to varicella, and if need be, especially if the donor tested positive for any genetic disease, then her partner will need to be tested to make sure, that there is no 25% odds of a baby being born with the disease. One thing that is really important is if the woman is of an older age, like 45 or above, or 50 or above, we strongly recommend that they meet with the MFM prior to decide to proceed. There has been so many reports of women in their 50s dying during the pregnancy because of complication of hypertension, ruptured aneurysm, intracerebral bleed, etc. So we want to make sure that they are healthy, that they don't have any comorbid conditions, and they understand the risk they're putting themselves by deciding to get pregnant at a later age. So again, evaluation of the egg donor, make sure she's healthy, she doesn't carry any disease that could be passed to the patient or to the future child, but also evaluation of the recipient to make sure that psychologically and medically she's able to proceed with an egg donation and with a pregnancy. There is many ways of choosing a donor. We have anonymous versus non-donors. If a donor is working with me, ideally, and if we choose that donor, we prefer to keep it anonymous, unless, the donor agreed to meet with the intended parents in the futures. So there are some donors that are willing to be identified later. There are donors that are willing to meet with the recipients, discuss the egg donation process, make sure she's comfortable donating her eggs to that couple, make sure, they have the same values, etc. There are donors who want ongoing relationships with the recipients. They want to meet the baby in the future. They want to be part of the life of that baby. And, it depends on the couple. I think just from experience, most recipient people would like to keep the donor at bay unless they know that person. They want to feel, because they're always scared, is that person going to interfere with their life? Is it going to cause any problem to the baby, etc.? And again, this is all part of the psychological evaluation of the donor and of the recipients that is done prior to proceeding with this. No single type of arrangement is right for everyone. each presents unique challenges during and after the donation. Our lawyer, the lawyer who works with our donors, usually put a clause in case in the future, let's say the kid has cancer, he needs a bone marrow transplant or anything, will it be allowed to reach back to the donor? So there are some clauses that the lawyer can add, and as long as the donor understands those and agree to them, that's perfectly fine. I think though, now with 23andMe and Ancestry and everything, it's kind of difficult to, keep the lid on anonymous donation. People seems to find easily who was the egg donor because of all those tests that are available to the public. And again, this will need to be part of the informed consent and of the counseling of the donor in case she's not really interested, in this happening in the future. One question that keep coming up from the donors is, can I donate more than once? There are really no firm rules about how many times a woman can donate her eggs. There was an article a few years ago in the Washington Post where some women who donated their eggs complained that it became infertile because of that. Now that there is no scientific proof to that fact, the eggs that a woman is using are the eggs that were gonna get wasted anyway, that specific menstrual cycle. So there is really ideally, there shouldn't be any long-term impact on a woman's health and fertility in the future. But this question keep popping up, and I guess it is a concern. It's a concern for the donor. It's a concern for us when we counsel the patient about possible donation. So because of that, we do not recommend that a person donate multiple times. In addition, our programs, like any other program, is required by the American Society for Reproductive Medicine, as well as by the New York State Health Department, to limit the number of children created using the same donor. Usually that number is 5 in an area the size of Monroe County or upstate New York. They don't want a donor to donate more than 5 times or to create more than 5 children, because of the fear, number one, that those kids might meet in the future, not knowing that they're related. They may have a romantic relationship, they may get married, they may have children that may lead to increased health concern in potential offsprings, etc. So for this reason, there is like a statistical calculation that we use to try to limit the number of children which are created using the same donor. The fear though is that if we work with the donor and we said, you've donated 2 times, you've created 3 or 4 children, this is done. The fear is that she will go to another program and donate her eggs there. So again, something to keep in mind during the counseling of those donors, that listen, it's not a good idea to give more than so many times or to create more than so many children. I know with sperm donation, it's different. We hear of this super sperm donor was like 70 children and they all meet together, etc. And that ideally also is kind of against the rule or the requirement of the American Society for Reproductive Medicine. But then, as I said, it's hard to stop people from doing what they want to do. What is involved in the oocyte donation process? It's exactly the same as when a woman go through in vitro fertilization. So basically, the egg donor is going to get injections of FSH and LH to try to develop a good number of eggs. When the eggs are mature, when the eggs are ready, they're given the LH surge in the form of an HCG shot. They're put under sedation. It's usually conscious sedation, not general anesthesia, usually an average of 10 minutes. And during that time, the oocytes are retrieved using an ultrasound guided needle. Honestly, the discomfort associated with the process is relatively minimal. In other words, the first thought is if it was really painful, those donors will never come back to give a second time. But just from our IVF patients who go through the same process, they don't seem to have any bad pain following the procedure, nothing that Tylenol or Motrin should not take care of. The eggs are then fertilized using the recipient's partner sperm or a selected donor sperm, and the embryo is then transferred into the recipient's uterus. For our anonymous donor, we usually don't tell them how many eggs we retrieved. You know, they usually ask, oh, that many eggs did you get? Did the woman get pregnant? We usually try to keep that information, you know, not to share it with the donor. And it's part of the informed consent too, that they will not be told if any baby was born from their eggs, unless, again, it's not an anonymous donation. Now, there are two kinds of eggs that are used: fresh donor eggs and frozen eggs. Fresh donor eggs mean that we select, or the patient bring a donor, we stimulate them ourselves, we retrieve the eggs, we fertilize them with the sperm, and we either freeze the embryo to transfer them later, or we do a fresh embryo transfer. But those are fresh donor eggs. In other words, the donor, all the eggs are gonna go toward that specific recipient where they had a contract signed together. The other option is for people to buy frozen donor eggs. What does that mean? There are multiple egg banks whereby they have young women volunteering to donate their eggs. The egg donor basically receive the same treatment. They receive FSH and LH, they receive their HCG shot, they go through egg retrieval, and then the eggs are frozen, and then they are sold later as a cohort. Usually an average of 6 eggs are sold to a patient, you know, and then they are either shipped to our program where we thaw them and we fertilize them, or sometimes we ship the sperm to that egg bank. The eggs are then fertilized, and then the embryos are sent to us. One of the advantages of a frozen donor eggs or of a bank is that they may have more donors available. There might be a wider variety of donors that might be available, so the patient will have more choices rather than having only 3 or 4 anonymous donors to choose from. Usually they're given a picture of that donor. Every bank is different, but ideally they're given a picture of that donor when she was a young kid. They're given a lot of information about that donor. That donor has been screened exactly like we do it in our office for genetic diseases. She's been screened for infectious diseases. She went through a psychological consent, etc. So egg bank versus frozen donor eggs versus fresh eggs. Is there a difference between them? Well, we know that fresh eggs have better success rate than frozen eggs. If you remember, we started freezing eggs barely maybe 6-7 years ago. So it's kind of a new technology, and we can freeze embryos beautifully. You know, if you freeze 100 embryos, you're able to thaw 100 embryos usually without any problem. But if you freeze 100 eggs, you may not be able to recover maybe 50, 60, 70 eggs, but never 100 eggs. So there is a loss of eggs with frozen eggs compared to fresh eggs. At the same time, with frozen eggs, there are usually fewer eggs for treatment because the bank is selling frozen eggs by the number. You know, like 6 eggs might be $16,000 to buy 6 eggs, compared to an anonymous donor who may get paid $10,000 to go through the process. And we may recover 10 eggs, 15 eggs, 20 eggs, 25 eggs, depending on her age, depending on her ovarian reserve. So we tend to get more eggs with fresh eggs. More eggs means more embryo, which will significantly increase the overall chance of success. But also there might be more embryos frozen to be used in the future. So if this couple want to have a biologically related child, they can just thaw those embryos, transfer them, and get pregnant with another kid, and they don't have to go through another donation process. Donation with fresh eggs is more cost effective. Again, it usually costs less. It's usually more eggs, more embryos, definitely more cost effective. The frozen eggs are usually split. What do I mean by that? You know, when a women donate her eggs to a bank, they tend to overstimulate them. They may get 30, 40, 50 eggs. Let's say they get 40 eggs and they're selling 6 eggs to each couple. This is at least, you know, 6 to 7 couples that are receiving those eggs. So those eggs tend to be split rather than with an anonymous donor through a program where the patient will get all the eggs for herself. The advantage, though, of frozen eggs is that it allows for faster, more convenient treatment. You know, you can go online right now, look at an egg bank, buy them. They can ship them to me in a week. They're ready to be fertilized and transferred maybe the next 4 or 5 weeks, compared to fresh eggs where we have to prepare the donor, we have to stimulate the donor, etc. So it might take much longer to proceed with a fresh cycle versus buying eggs from a bank. It's getting harder, you know, just from a practical point of view, it's getting harder to get donors into the IVF programs because they do get paid more by banks. You know, the banks tend to, it's a business, they tend to make much more money, so they tend to pay their donor much more money than an IVF program can afford. Paying donors has always been a major issue. You know, a few years ago, there was a big war between the IVF programs in Manhattan, where everybody starting upping the cost paid to a donor. It used to be 4,000, it went to 10,000, it went to 15,000. And then, you know, it became like literally a war between program. And then ASRM, our society, had to interfere and explain that, you know, what you're paying for are not really the egg. It's illegal to buy biological product, you know, buying eggs. What you're paying for is the time for the patient to go through the treatment, you know, time off work and all of that. That's what we're paying for. So right now, the cost is approximately $10,000 for a donor, but egg bank might pay more than that. Just, you know, penguin laughing, we've been reproducing with frozen sperm and eggs for years. And as I said, for us, frozen eggs have been maybe 5, 6, 7 years at the most. The outcome of egg donation really depends on many factors. The most important is the age of the egg donor. Again, the younger the egg donor, the better. It depends on the retrieval process, how many eggs we're able to get, the quality of the sperm, and the recipient's overall health. Is she healthy? Does she have any issue that's going to prevent implantation? Does she have any uterine anomaly that's going to affect that? As with all third-party reproduction processes, the recipient should seek counseling to explore emotional concern. You know, there is really a lot involved. And again, you just want to make sure that the recipient is really comfortable with the idea of using somebody else's egg, that she's not going to look at this child as, you know, somebody who's alien to it, somebody who's strange to her. We want to make sure that her relationship with her partner, if any, is not going to be affected by the use of a donor egg. Again, psychological assessment is extremely, extremely important. What's the long-term outcome? Well, the long-term outcome appears to be really, really good. One thing, though, I have to mention, every psychologist, when they counsel the couples, the recipient couple, they always mention to them that they should tell the kid at some point, you know, the child at some point, that she is the result of an egg donation. There has been multiple studies to that effect, and it was found that the disclosure appears to be related to a more positive psychological health outcomes for both the parents and the children. You know, the parents will not feel that they're hiding something from their child at all time. And the children seems to be accepting very, very well the fact that they were created. I mean, it's an act of love to go through all this in order to have them. They understand that this has been a great act of love, and it appears to be related again to a more positive psychological outcome. Now, families that are created through egg donation, and again, those are based on multiple studies, seems to function well in terms of child adjustment, parental psychological health, and parent-child relationship quality. And very few difference were found in egg donation parents' level of parenting stress in comparison with other family types. I mean, it's clear that somebody who went through multiple IVF cycle and then had to go through a donor IVF cycle knows how to handle stress. So they seem to have a lower level of parenting stress in comparison with other family types. I guess just to summarize this, the long-term outcome of kids born through egg donation is very good for both the children and their parents. I left at this slide because, we get a lot of people who come to us who want to donate eggs, and, not to be mean or vain or anything, but sometimes you have people, they come in and you look at them, like you review their history, you look at their physical appearance and everything, and you feel uncomfortable offering such a donor to your patients, if you know what I mean. So, just like when somebody go to donate sperm, they're screened physically, etc., before they're allowed to donate. It's kind of the same. So this lady, she came with her kids, and the doctor is like, no, thank you. We don't need any more eggs right now. I will talk now about surrogacy. So basically, a surrogate mother is the woman who's pregnant with a child and she intends to relinquish it after birth. Surrogate basically comes from the Latin, it means substitute. So she's kind of the substitute mother, the person who's gonna carry the baby. Once the baby's born, she's gonna give back the baby to the biological parents. The surrogate becomes pregnant via embryo transfer with a child of which she is not the biological mother. Now, in the past, there used to be true surrogacy where the surrogate will be using her own eggs, but it will be a different sperm, somebody else's sperm, and she will carry the baby, and then she will relinquish the baby to whoever gave her the sperm. But the gestational surrogate, she just carried the baby, and neither the egg nor the sperm are hers. She may have arranged to relinquish it to the biological mother or father to raise, or to a parent who is themselves unrelated to the child. I mean, if you think about some celebrities who had children where they weren't the sperm donor and their partner wasn't the egg donor, and the baby was basically created with an egg and sperm, which was carried by a surrogate mother, and then they raised the child, she relinquished it to the couple who paid her to carry the child. The surrogate mother is usually called the gestational carrier. There are few types of surrogacy. There is altruistic surrogacy. Basically, the surrogate is not receiving any financial reward for her pregnancy or for giving up the child. And then the couple, though, who's getting the child has to pay all the expenses that are related to the pregnancy and birth. They have to pay for all those expenses. Then there is the commercial surrogacy, where a gestational carrier is paid to carry a child to maturity in her womb. And, sometimes it's referred to by some offensive terms like wombs for rent or outsourced pregnancies or baby farms. And this is an issue that comes with people who are against surrogacy, who disapprove of the whole surrogacy, that you're just using somebody else's womb because you don't want to use your womb. Most of the surrogates that I have worked with were altruistic surrogates. In other words, they were not paid for that. We had mothers who carried babies for their daughters because their daughters had a hysterectomy or could not carry a pregnancy. We had siblings who carry pregnancy for each other. We had a patient who did not have a uterus who needed a surrogate, and then a woman without ovaries carried her baby, and then later on she donated her eggs to that woman. You know, a lot. But altruistic surrogacy, honestly, is not rare at all. A lot of people will be willing to carry a baby for somebody else without getting paid for it. What are some indications for surrogacy? Well, usually it's a disorders which is confined to the uterus. The patient may have had a hysterectomy. She may have had a myomectomy that has damaged her uterus. She may have had Asherman syndrome, you know, a DNC gone wrong, or any endometrial procedure that went wrong, a lady who had endometrial ablation, and she want to have more children in the future. But also it could be a medical condition in the wife that may preclude her from being able to get pregnant. You know, we have people with heart disease whose cardiologist said you cannot carry a pregnancy, you know, you will die. And then they do need a surrogate. People who have had complicated pregnancies previously where they had severe preeclampsia, you know, at 24 weeks and had to deliver very, very early. And this repeated itself, and now they decided, you know, they cannot take this risk anymore and need a surrogate. But also we use it in people who had failed multiple IVF cycle. You know, patient undergo IVF, you test the embryos, they're perfectly normal. You put them inside this woman's uterus, she doesn't get pregnant or she miscarried the pregnancy. You do that again a second time, a third time. And then you know the embryos are normal because they were tested, they were euploid. And so the only option out there is that there's a problem with the uterus. We don't know what the problem is. We investigated, we did biopsies, we ruled out endometritis, etc. But the patient keeps failing her IVF cycle. That's another indication to use a surrogate. I know that over the past few years, there have been a lot of talk about uterine transplantation. And we always wondered about, you know, uterine transplantation. I mean, it's a complicated surgery. It's a difficult surgery. The uterus may be rejected. The patient may need to be on immunosuppressant, so she does not reject the uterus. It's unknown if the uterus will be perfused well enough, you know, to support a pregnancy. For this reason, you know, I always wonder why those women decided to go through that process when for much less money they could have had a surrogate carry the baby for them. What are the arguments for surrogacy? Well, it will allow a couple to have a child when they would otherwise be unable to do so. You know, that's the only option for them, to have a child. There is definitely a scarcity of adoptable children. You know, we see that all the time. People used to go to Russia to adopt. This is not open anymore. People used to go to China to adopt. This is getting more and more difficult. They used to go to Korea, etc. So adoption is difficult. I have a list of people, you know, who are waiting to adopt either an embryo or a child. And, you know, they wait forever to be able to do that. So because of that scarcity, there is definitely an argument for surrogacy. Plus, I mean, reproductive rights in the United States are very important rights. And, you know, people have the freedom to decide whether and when to conceive or bear a child. And, you know, that freedom is highly valued and it should be protected. So those are all arguments for surrogacy. Now, if you remember a few weeks ago, the Pope on his Sunday, you know, came out against surrogacy, and he asked that it should be banned. And I mean, the reason he was given was it could harm the child. You know, this is a child that's being carried by somebody else, given away to somebody else after the pregnancy. There might be a lot of psychological issues there. But there is also harm to the surrogate. You know, she's carrying a baby. I mean, we all know that pregnancy is not an easy is not an easy thing to go through. Carrying extra children other than your own, is gonna put a lot of, I don't want to say damage your body, but it's gonna, add to some harm to your body. But more importantly, that surrogate, she may not give enough attention to her own children because she's pregnant, she has to go to her appointment, she has to deliver this, and that. So there is also harm to the surrogate and her children. And there is thought to be harm to society by the fact that, let's face it, people who can afford surrogacy are richer people, and usually people who are the surrogate are poorer people. Most of them are getting paid to go through this process. And so there might be some harm to society in that way, is that there is people are taking advantage from people who are less financially stable than they are. So those are arguments against surrogacy. So if after careful consideration of all the arguments, a physician chooses to facilitate or recommend surrogacy arrangement, then every precaution should be taken to prevent medical, psychological, and legal harm to the intended parents, the potential surrogate mother, and the prospective child. I mean, all of those three people need to be well counseled, the child later on when the child is born, in case, because they're usually told that somebody else carried you, etc. The intended parents, they need to be ready to deal with all of this, where did this baby come, societal people asking some, so where did this baby come from, etc. And the potential surrogate, I mean, she's carrying a baby that she's given away. People may ask the husband of the surrogate, oh, congrats, your wife is pregnant. Well, she's really carrying the baby for somebody else. I mean, it put a lot of pressure on everybody, and everyone should be counseled adequately before proceeding with such an endeavor. The payment to the surrogate is a very contentious topic, as I mentioned before. What is payment made for? Well, the payment is really made for the patient for the time she's going through the process, for the time she's going through the doctor visit, the doctor for her prenatal visit, for all the testing she's going through. Is the payment offered or is the payment requested? A lot of people may offer to carry the baby, and then the intended parents may be generous enough and offer the money compared to somebody who is requesting the money. And is the payment likely to lead to the exploitation of the potential surrogate mothers? It does a lot of time. A lot of people who pay a surrogate seems to want to control every aspect of the pregnancy. They want to make sure she's eating okay, she's taken the vitamin that they would have taken if they were pregnant, that she's not smoking, that she's undergoing this or that test, etc. So the payments, can lead to that exploitation. And again, this is part of the counseling for the intended parents, that they really cannot interfere with the pregnancy itself. Now, multiple studies have been done about the surrogate mothers, and those mothers are as normal as anyone else. There is nothing wrong with them. They're not like crazy, want to carry a baby for somebody else or anything. They're just normal women. And, they're average mothers. They're just trying to further the goals of their children and families. For them, it might be a good financial benefits that will help them, further the goals of their own children and of her own families. Now, money is an important motive to many surrogates, but again, the studies shown that it's not that primary motive, that the fact that they're helping somebody, they've been through this themselves, they know the importance of having a child, they know how important the child is, and part of their motivation is to try to help another couple, become parents also. The cost can be really expensive. There are now agencies that offer what they call a surrogate package. In other words, they offer the surrogate, they offer the counseling, they offer the legal the legal contract, they offer the cost during the pregnancy. And usually, I mean, it can cost anywhere, if you look at those agencies, $125,000 to almost $250,000. But honestly, it does not have to be that expensive, especially if somebody does not go through an agency. But the cost involved an initial evaluation, meeting with the surrogate, making sure the surrogate is a good surrogate. She doesn't have factor 5. She's not going to blow, a pulmonary embolus when she's pregnant. She doesn't have high blood pressure that's going to put her at risk. She didn't have 3 or 4 C-sections before that's going to put her at risk. So initial evaluation is important. The psychological evaluation, they have to meet with the mental health provider. Usually what happened, the mental health provider will meet with the surrogate alone, will meet with the couple alone, and then will meet with both of them to explore any possible problem that could arise in the future. The legal agreement, most lawyers who deal with that though have a standard legal agreement, so that by itself should not be that costly. The IVF cost, the intended parents have to go through IVF, create an embryo that will be transferred into a surrogate, preparation of the surrogate for the embryo transfer, the payment to the surrogate, and then the unexpected cost. What if it's a miscarriage? The surrogate, have to undergo a DNC. This is still, a payment due by the intended parents, even though they did not get the baby that they wanted, but it's their responsibility too. Let's say she needs an amniocentesis. She needs some extra testing. It was a C-section rather than a vaginal delivery. So all those costs are gonna add up. And again, this will be all in the legal agreement, but the couple need to be aware of those unexpected costs. And the couple will really have to understand that they're not paying to get a healthy baby. They're paying for this whole process. They're paying for the time, for the treatment, for possible complication, hoping to end up with a healthy baby at the end. The role of the OBGYN, I think one of the most important things to remember is that the OBGYN should avoid any conflict of interest. The OBGYN should look at each person interest alone, and then this is my patient, the surrogate is my patient, this is the one I'm taking care of, this is the one I'm gonna counsel, this is the one I'm gonna tell her it's a bad idea for you to get pregnant with somebody else's kid, So the OBGYN really has to discuss the ethical, legal, and medical issues with the recipient, with the surrogate, as well as the intended parents. They want to make sure that appropriate procedures are used to screen the intended parents and the surrogate mother, all the infectious disease, the vaccine status, all of that. Everybody need to be referred, everybody involved need to be referred for psychological counseling. And very important, again, what will happen, let's say, if, the surrogate get pregnant, but the baby has Down syndrome. The intended parents want her to terminate the pregnancy. The surrogate refused to terminate the pregnancy. I mean, there is a lot of issues that are gonna arise and that will need to be discussed with both people involved, the surrogate and the intended parents. And as I said, it can get a little bit complicated because, I mean, the intended parents are going through this process assuming they're going to get a healthy baby, but it could be a pretty difficult road to get there. And the job, I hate to say that word, but what the surrogate is doing, she's following the advice of her doctor, she's getting her hormones, she's getting prepared, she's getting the embryo transfer, she's getting her shot of estrogen and progesterone, she's doing everything, but she cannot promise that everything is gonna go as planned and give a healthy baby to the parents. The prenatal care of the surrogate, she should be cared of as any other obstetric patient, and she should be the only person that will give consent for any intervention management of the pregnancy, labor, and delivery. In other words, the intended mother is not going to come and say, hey, I want you to deliver by C-section at 38 weeks. She has nothing to do with that. The OBGYN, the surrogate, is her patient, irrespective where the baby is going after delivery. And the patient should be the only one giving consent to anything that's going to be done during this pregnancy. More importantly, the confidentiality between the physician and the surrogate should be maintained. The doctor is not going to call the intended parent and say, hey, you know what, she's smoking, or she gained too much weight, or, you know, she has diabetes now. This should not be allowed. The confidentiality should be completely maintained. Previous agreement between the surrogate and the intended parent should not affect the physician care. Again, what happened between the surrogate, what she agreed with the intended parents, I'm the doctor, I'm your doctor, you're my pregnant patient, this is what we're gonna do, this is what I would recommend. What you agreed with those people before you became pregnant is not gonna affect my treatment or how I'm gonna manage you. Role of the hospital, that can be a little complicated. You know, the hospital, the OBGYN need to inform the hospital when a surrogate is coming to labor and delivery to give birth. Because again, she's gonna give the baby immediately after birth to the intended parents or 2-3 days later. So the L&D staff should be notified of a forthcoming surrogate delivery. Prior contact with the intended parents can be useful. You know, maybe the intended parents want to come, just like a pregnant woman, they may want to come visit labor and delivery, look at the nursery, see what's going on there, you know, how is the baby fed when the baby is born, and all of that. And usually, again, a team that include administration, risk management, birth certificate clerk, because, you know, the birth certificate is going to include the name of the intended parents and not of the one who is delivered. You know, few things may arise when we put an anklet on the baby. Should it have the name of the woman who delivered? Should it have the name of the intended parents? All of that need to be worked out ahead of time. And risk management is important because it did happen a few times where the mother delivered the baby, the surrogate, and said, no, I'm not giving the baby away, I want to keep it. And, you know, or the baby was born with an abnormality and then the intended parents just ran away from labor and delivery. So all of that needs to be prepared ahead of time. Again, hope for the best, plan for the worst. Postpartum care, very, very important for the surrogate. You know, she's gonna be left with no baby, with nothing. She's going home, you know, she's going through the postpartum pain. We need to watch for postpartum depression. We need to follow her up closely, offer her contraception if needed, and very importantly, stop lactation since she will not be breastfeeding any child. One thing that, you know, intended parents ask us is, can you induce lactation? Because even though she did not carry the baby, she would like to breastfeed the baby. And it can definitely be done, you know. We start those women usually when the surrogate is around 20 weeks, we start the intended parents on estrogen. Later on, we add Reglan. We start, you know, the pumping process to try to stimulate the breast. We decrease the dose of estrogen to let the milk start coming. It does work. It is a little tedious, but it works, you know, for women who are interested in breastfeeding the child born through a surrogate. We can definitely get them ready and prepare them. I understand that she didn't have the chance to carry the baby. At least she would like to have the chance of breastfeeding this baby. And as I said, there are multiple ways of inducing lactation. It's easy to do. Other option include using this service, you know, it's a bottle, it's a small tube that's attached to the nipple, and then the baby, you know, it could be donated milk or it could be formula, and then the baby will be able basically to suck on the nipple of his biological mother and do get some milk. La Leche is very helpful in that instance. They have multiple protocols that they can help with. They have this equipment available to give to the biological mother if need be. And usually we advise, the intended parents to check with them ahead of time and to go through some counseling to that regard. We do egg donation, we do surrogacy at Boston IVF. The couple come to us, they express interest. We look at multiple options of finding a surrogate. We counsel the surrogate. They go through our psychological evaluation, they go through legal counseling, signing of the legal agreement, and then both of them go through the laboratory evaluation. We try to synchronize the cycles as much as we can. In other words, we would prefer to transfer a fresh embryo into the surrogate rather than a frozen embryo, but we can do both. We try synchronizing the cycles, put both on oral contraceptives and then start them all, let's say, on a GnRH agonist to synchronize their cycles. So once the embryo is created, we can place it immediately into the surrogate. We provide luteal support, we provide early pregnancy follow-up, and once we're comfortable, around 9 weeks that the pregnancy is proceeding adequately, the surrogate is referred to an obstetrician. New York State, few years ago, actually, before 2021, surrogacy was quote unquote illegal in New York State. In other words, the woman who delivered the baby was the mother of the baby. And the way we went around that was that the baby was given for adoption to the intended parent. So there will be a legal contract drafted way before the surrogate got pregnant, that state clearly that the surrogate is going to give the baby for adoption to the biological parent. At that time, it was illegal to pay the surrogate. And just a little anecdote, there was this male couple, same-sex male couple who had a surrogate carry a baby for them, and they paid her $35,000. And when the baby was born, she refused to give the baby to the intended parent. They sued, they went to court, and the judge did something interesting. He gave the baby to the intended parents because there was a contract signed ahead of time that, she will give the baby for adoption to that couple. But he took back the $35,000 from that woman because it was illegal to pay a surrogate in New York State. But since February 15, 2021, this has changed. Now gestational surrogacy in the state of New York is legalized. Gestational surrogacy organization, though, have to be licensed in New York State. Same for sperm bank, same for egg bank. They all need to be licensed in New York State. And I guess the best part of this law was that it established protection for gestational surrogate. As well, it make it very simple to establish legal parental rights for parents who rely on ART to have children. In other words, it's a really good law. It made it much easier for the surrogate. The intended parents cannot just say, oh, we don't want this kid, he has Down syndrome or something like that. And the surrogate cannot go back and say, hey, I want to be part of this baby's life. I want to take that baby back, etc. So it offers protection to both the surrogate as well the biological parents. Now, few things about that law. It only applies when the gestational surrogates reside in New York and or delivers the child in New York State. The intended parent can reside in or outside of New York State. However, at least one intended parent must be a United States citizen or a lawful permanent resident of New York State for at least 6 months. And I guess the reason this is done is to try to decrease the number of commercial surrogacy, people coming from out of the country trying to have a baby here, etc., trying to avoid those issues. Thank you so much for listening, and I'll be happy to take any questions.
Thank you, Dr. Mroueh. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Mroueh, our first question is, if a patient knows they want to use a donor, should they reach out to you or to a donor agency first?
I think reaching out to us will be easier. Let's remember that an agency basically is a business, and I think adequate counseling about the choice of a donor, there are some questions that a recipient should ask the egg bank, the agency, that they may not know about, and we will provide them with their answer in order to choose a good donor. How many times did this donor has donated? How many children has this donor produced before? How many eggs did you recover from her the last time you took eggs? A lot of questions that can help with the success of this whole process. So I think they should reach to a reproductive endocrinologist, a fertility specialist beforehand for counseling purposes prior to reaching to an agency.
Thank you. The next question is, regarding the potential psychological issues, are there any studies showing rate of regret in cisgender parents pursuing donor eggs?
All the studies show positive rather than negative outcomes. I have to mention my personal experience. I honestly have never seen like a negative psychological outcome on anybody involved. And all the studies, again, report positive outcome for the donor, for the recipients, and for the children.
Thank you. That was our last question. Thank you, Dr. Mroueh, and thank you everyone for attending today's webinar, Third Party Reproduction 101. If you have any other questions, please contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help us with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Dr. Jamil Mroueh, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Mroueh.
Thank you so much, Elisa. Thank you everyone for attending. Have a good afternoon.